I'll invite the next speaker now, Dr. Revathi. And ma'am will be speaking about how best to repair traumatic corneal or corneoscleral tears. Meanwhile, any comments from the panel about the use of the dried amniotic membrane vis-a-vis the cryopreserved? Sir?
I have no experience on dry amniotic.
We
Rather,
had used a couple, but we were not very happy. It doesn't work.
okay.
Yeah, thank you. For a change, now we are going to look at the corneal tear as such, not the perforations. And here, the aim is most of them may be medical legal also. The aim of the repair should be depends on the severity. If it is simple wound, we have to try to regain the corneal contour and minimize the scarring for the early visual rehabilitation. But in case of severe injuries, the aim is to reconstruct or regain the anterior segment as such, and then later we can do the further visual rehabilitative procedures. So the principle, these are semi-elective procedures. So injury can be within initial 24 to 48 hours, we can intervene anytime, provided that we protect the patient with oral antibiotic coverage or systemic antibiotic coverage, and do the proper investigation, assess the extent of damage, and then go for the plan the surgery and go for the repair. And also remember, it is essentially a microsurgery, and we have to achieve the functional results also. So the sutures we follow is we use is 10-0 nylon, and what we should remember, a deeper curved needle, 160-degree needle, spatulated needle will be more useful for deeper sutures, and the spatulated longer curved needle will be used for the lamellar injuries. The suturing technique, as we know, we have to go full thickness almost and equidistant, so that the compression zone will be covered with overlap, and there should not be pouting either internally or outside the wound lip. The corneal tear suturing, first go for the identify the landmarks, and the prolapsed tissue usually will be covered with a fibrinous tissue. Separate it bluntly, like with a blunt dissection, and remove it. And then if the tissue is viable, we can reposition it. We need not sacrifice it all the time. And the contour of the injury, like the tear, we have to assess, and we can follow the same contour, the landmarks, for proper and approximation. And we can, some of this wound, when it is central, we can use the same wound to wash off the cortex and other internal vitrectomy for other purpose also. So first fix the limbus, and then you can see in this injury there are curvatures. It's like an almost S-shaped or double S. Then use the same curvatures as the landmarks for proper approximation with full thickness sutures. And this approximation should be, as I said, just the tightness should be just needed to approximate. We need not tighten it too much. But always remember that there will be edema in this tissue, so that once the edema reduces, there may be loosening. So accordingly, we have to do. And this is if the injury is too extensive, then repair as much as possible. If there is a tissue loss, we can use either a fibrin glue or a tissue glue. And as Dr. Mentioned already, we can use even the tenoplasty and other things also here. And the scleral wounds along with the corneal wound, then we have to delineate the scleral wound, occur proper hemostasis, then excise all the prolapsed tissue, and then we can use half thickness bites here. We need not go for full thickness as in corneal. That's what we should remember. We can use 9-0 nylon or 8-0 vicryl sutures, and then suture it to the full extent. And if it is going beyond the muscle insertions or beyond the reach, then we can leave them on. And then come to the corneal part, and as usual, clear the anterior chamber from all the unwanted tissue, and then you can address the cataract also at that time. If the anterior capsule is breached, then do a proper vitrectomy. There should not be any tissue incarceration in the wound. And a wound like this is easier to manage because it's only a straight wound, and we have to first fix both limbus, and then in between area has to be covered with equidistant sutures. And so this is a post-op within 2-3 days. The result will be like this. One word of caution: in occult scleral injuries, we have to suspect this whenever there is hypotony, chemosis, and extensive subconjunctival hemorrhage. Then usually the area of breach will be somewhere near the muscle insertion or the equator or the limbus. So if you are not able to see, patiently explore, find out the tear, and then suture it as such. So this main aim, especially in case of corneal wound, it is to regain the corneal contour. It's not enough just to suture. If you are losing the corneal contour, then it's not going to be. It's like a plastic surgery. That's what we have to remember here when repairing these wounds. Thank you.